get them out of pain. Yeah. And then, depending on your level, you look at least 2 to 1. So after 5 mil heel lift, you've got to make sure you got the forefoot up 50% of that as well. It's no good having people on a high heel. So you've got to actually make sure that that base is even, because as soon as you do that, you're going to change the stride length again. So, okay, they might be more comfortable when they're standing, but it's still not going to work when they walk. So at least probably start off at 50%. I probably wouldn't really ever go past 75%, if I have to give you a figure. In 30 years, I don't think I have had to go that far to get results. And most of the leg length discrepancies that are of that level are usually injury-based or polio or some sort of disease-based. It's very rarely that a normal human being comes in and they've got a real leg length difference. Functional leg length difference, yeah, a lot of them, but not necessarily a real one. And that's what I find, you know, a bit of a worry, that you get these people having heel lifts on there. They're not explained properly. Patient may not go back to their practitioner, so they wear this bloody thing for the next 10 years, and it can create other problems. So again, what's your treatment base? Explaining it to the patient why. And they have pretty good feedback if they understand what you're trying to do. Yep, but like I said, you can roll up a sock and stick it under your arch and make a big difference too. The ultra marathon, when I was doing a medical for that, my best friend was a Stanley knife and mud flaps. I used to steal lots of rubber off people, trying to fix people on the run. So, you know, it worked. It's just, so you really, yeah, you can make any functional change, but you need to recognise what's the problem, what functional change do I need to do, and then how am I going to do it? And that could be shoe correction. And there are boot makers around. They won't make the shoes now. I mean, they're all past that. You know, I think I've got one Italian guy at Fairfield that still remembers how to make shoes properly. And you got a lot of other areas that make shoes, but they cut corners. And a lot of my patients that get custom-made shoes are never really happy with them. So a lot of times I'd rather use, you know, a medical grade shoe, like the Dr. Comfort or the PW Minor or something like that. Because the trouble with the handmade shoes, especially in the old days, I had one lady came in, she would have been 4 foot 4 if she was lucky, built like a greyhound, and she had a discrepancy that far. So she came to see me because they did this shoe for her, and when she put it on, she couldn't lift her foot up. And I went, duh. But then, so that can be the problem with some of the shoemakers. They don't think, you know. And the old guys would have, what they would have done is, they would have hollowed all that out. Right? They would have structured something that wasn't heavy. So yeah, expertise isn't there. You know, I did 2 years of footwear when the surgical footwear school was still alive in the old days. So it's much easier. I know when a bootmaker's bull crapping to me than not, and I know what can be done and what can. Most of them are lazy. You know, it's much. Yeah, mate. Mud flat and a little angle grinder, you can do wonders. Yeah, so when we get back to that Hallux Limiters and the Jack's test and what the Dannenberg described. Dannenberg's a pod from the States, so he's sort of invented this orthotic that's got a drop in it. I think it's been around for a while, but he's refined it a little bit. And their study showed that there was a relationship between Hallux Limiters and spinal pain to deficient hallux extension. And it doesn't take a genius, you know. If your big toe's not walking and you're trying to get over it, it's going to create stress to your spine eventually. So that's when you start going this way, and that's when you'll walk with one foot doing that. And obviously not only the knee's going to go, but the back's going to go eventually, because you're not getting that kick-off, which is what you want. It's like, you know, your patient comes in, they may not need that. They may need just a slightly customised insert or a mud flap, as he's saying, and that might be enough. And, you know, it's trying to think back. Oh, yes, I had one patient that had a serious toe problem, and what shoes you always wear. She said, I always wear these shoes. So I checked the shoes out, and I think it had something to do with the brooch she had wrapped in tissue stuck up the other end of it. So when we removed that, the shoe was a lot more comfortable. So, you know, we've got to do whatever you've got to do to fix that patient, and that's the best I can do, best I can tell you along those lines. But don't get me wrong, making proper orthotics is not easy. You know, to have the mechanical understanding and also have the practical expertise in looking at that orthotic and foot in a 3D fashion and trying to envisage what you want to get out of that is not always easy. You know, people have talents in certain areas and people have talents in other areas. I've got podiatrists that are geniuses. They've got PhDs and they're wonderful. Couldn't fix a patient if they tried. But that's not what they're there for. They're there to do all the studies to see whether they can quantify all this stuff. So that's what you've got to look for, is someone that's really got the skills that you want to do that particular activity. So, you know, the effects, if the orthotic therapy is designed correctly with extreme control features, it will be effective long term. Answers your question. The orthotics last a long time. Should the patient be reviewed? Yes, because the effects are there all the time, and sometimes you need fine tuning. And that you can do because a lot of the corrective type of devices have a high memory, thermoplastics either inside them or part of them, whereas a lot of the air-blown rubbers, they compress. You can't measure that, so you lose. The biggest thing with foot orthosis is that the orthotic has to have as close a contact to the bone as it can have to be effective. So you've already got a pile of meat in between there and there, so if your orthotic crush as well, you're not going to be as effectual as you should be. So a rubber orthotic made exactly the same as a corrective orthotic with some form of thermoplastic are exactly the same for the first 6 weeks. Just like when you go and buy your new runners, they feel great for the first 6 weeks. And then they start to lose their little bit of oomph. And then, you know, as it goes along, it's not worn out, but it certainly doesn't have the same bounce and the same protection that it had when you first started. And that's just the material densities and what's available.
If you're an athlete.
Yeah, because you're also looking at, once you get specific with the sport, they're not going in a straight line. So then you start getting transverse movements, so you start getting blistering, you start getting other issues. Same with shoes if they don't fit properly. So some people can handle it, the whole control, they've got such a bad foot that they need that to function. Other people, I've got some that they don't use their orthoses at all when they play, right, for the 60 minutes or 90 minutes, but they might use it for training, and they may use it for strength training and cardiovascular, but they may not use it for ball skills. Okay, because the orthotic also leaves you with a residual effect. Your foot will function without the orthotic for short periods of time. How long depends on the individual, the deformity, whatever. But I look at my example. My right knee was blown out when I was 20. I always have got great genetics, so my feet have always been a problem, and my legs have always been a problem in position, and I've worn orthotics ever since then. When I first started wearing orthotics, I couldn't walk from the front door to the mailbox in bare feet without the foot or the knee or something giving me some issues. And since I've been wearing orthotics, I mean, I can wear thongs for a day now and not worry about it. So I have got residual effect. Am I cured? No, I've still got crap legs. And the MRI says my right knee's about 75 years old. So, but it's still functioning, and the surgeon still hasn't had a shot at it yet. So, you know, it's not a good knee, but I don't care, as long as it keeps moving, and that's what I tell my patients. Okay, I can't run anymore on concrete because it kills, but I can run in the pool, I can ride a bike, I can play tennis, as long as I don't put my body on the line, and quite enjoy it. I even snow skied for 10 years, from coffee shop to coffee shop. You know, so it's all relative to your type of body, type of problem, of what effect you want. And some of the athletes, they expect too much because they've done too much damage, and orthotic therapy is not a quick fix. That's your guys. You guys do quick fixes. And that's the thing. So that's why you don't see a lot of podiatrists next to a field. What's the point? You know, I can take with the best of them. I can massage, I can deep tissue, I can acupuncture, I can dry needle, I can do all that stuff. But that's not my primary area. There's other people that do better. So I'm not an acute therapist. Sorry.
In the movie Lethal Weapon 1...
When he was sitting on the toilet or another...
No. He had to take his shoes and socks off and make fists with his feet, and that was to help him get over his air sickness. But my question to you is, I know there's not going to be a cure-all, but is there one, I know, balance, you know, wobble balls, all that, forget that. Is there one exercise for the feet that could kind of be done for the general population regardless of any problems?
Well, I really believe it's the midfoot's the real issue. So the deep muscles there, because everybody uses the big foot muscles. You know, your toe extensors, your toe flexors, they're all in your leg. They use them, but a lot of times it's the lumbricals and the deep muscles that aren't getting used. So anything where you can actually get that foot to contract, as you're saying, and get the first ray working, then that's fine. So you make a fist. Well, I get patients, some of my patients aren't all that clever, so they need something to do. And you give them a towel, and I get them to, I want the towel near your foot without bending your toes. That's a challenge. I really don't care whether they ever get the towel there or not, but it gives them something to do. They bend their toes. I want that intrinsic work on. I want that. And then, okay, you've got, you know, you can do squash ball, do individual toe structure, elastic band around there, try and get your bunion going. There's lots of other different ones, but that one, to me, they're the muscles that you need to really concentrate to get going, to help the foot quickly.
I don't know.
Well, Charcot-Marie-Tooth is sort of attached to diabetes a lot, but basically it is a disease. The foot structure contracts on itself. It's not just the tendons, it's actually the bone structure starts to change. The joints, it's not really arthritis, but the joints all get screwed up. You get a lot of rheumatic changes, so they get stiffer. Eventually the end result is that the foot it self-destructs. So, you know, you've seen that when they put all that dynamite in the building and bring the building down on itself, that's what the foot does eventually. So that's what they're trying to avoid. So they're going to try and arthrodese the foot in a better position. There's nothing else they can do. Orthoses help it, yeah, they help, but it's a disease, so it's very difficult to control. So that's the type of foot that ends up, you know, you probably need to have some form of therapy just for comfort more than function, because I don't think you'll get function back. It's the type of foot. Sorry?
Even after surgery, that's what he's...
He'd be a damn bloody good surgeon if he's going to get those joints working again. I don't think God actually lends himself out lately, so it's really up to these guys. I know, but that's the way it is. But then, you know, orthotics to stabilise it afterwards, and the rocker bottom shoes we're talking about, maybe not quite as dramatic as those shoes, but all that will help him function. And that's probably the end result with that. But it's a disease. It's like rheumatoid arthritis. Yeah, rheumatoid arthritis, I see them regularly. You know, that's the orthotic changes, their foot changes. You know, it can be great for 4 years, and then every month they have to see them and tweak them. And then it might be right for another 4 years. So disease does have a different influence on some of those things.
Okay, would you please thank Mr. Laurence Sidari?
That's right.